Welcome to PGOG, postgraduate class in obstetrics and gynecology. And now we are at the end of our, we are at the end of our polycystic ovarian syndrome series. First, we had seen pathophysiology of PCOS, then the diagnosis, and now we are coming to the third part, that is the management of polycystic ovarian syndrome. In the management of patients with PCOS, it is called as a two-pronged approach whenever we are managing the patients. Two-pronged is one part is whatever symptoms patient presents with, we need to take care of those symptoms. And second part is to prevent the long-term sequelae. So in symptoms, first, as a menstrual dysfunction most common, we need to take care of that, or features of hyperandrogenism or hyperinsulinemia they are there. We need to treat the patient accordingly. And if patient is desirous for pregnancy and she has infertility, subfertility, then we need to take care of the anovulation, chronic anovulation for the treatment of infertility. But along with that, whenever we are doing the reducing the symptom burden, what we need to understand is it's our duty as a obstetrician and gynecologist to prevent long-term sequelae, which are very, very dangerous and adding to sometimes to even more long-term morbidity as well as mortality. We need to take care of these long-term sequelae whenever we are treating patients, such as prevention of endometrial carcinoma or endometrial hyperplasia, or protecting the endometrium against unopposed action of the estrogen. And secondly, development of metabolic syndrome. With metabolic syndrome also, there is so much of increase in patients' morbidity, as well as it can lead to within ischemic heart disease, such as or uncontrolled diabetes. It can even lead to mortality also. Lifestyle modification, it is the first line treatment for overweight and obese PCOS patients, especially almost in more than 50% of the women with PCOS, they are obese or overweight. And for them, always whenever we are prescribing, rather than prescribing any drug or rather than prescribing any specific medication or intervention, the most important part is education, counseling, encouragement, and follow-up, mainly to see for lifestyle modifications. Now, PCOS, polycystic ovarian syndrome, is an endocrinopathy, which once a woman has, it stays usually throughout her life. And that is why these lifestyle modifications also need to be followed for a very long duration. And that is why it is very, very important to always educate, counsel, encourage, and keep a follow of whether the woman is able to follow whatever modifications we are suggesting. Weight reduction forms a very important component of the management in obese PCOS, and the studies have shown that even if there is a slight reduction in the weight, 2 to 5% of weight reduction also is very, very helpful for reducing the symptom burden as well as for improving the chances of pregnancy. Weight reduction can be done by reducing the calorie intake and with the help of moderate exercise. If it is a vigorous exercise which is advised, then usually it is not very sustainable, and that is why moderate exercise is usually advisable. It will take care of obesity as well as it will help in prevention of diabetes and ischemic heart disease. What is the place of metformin? So in euglycemic women, where use of metformin for weight reduction, at present there is no enough evidence and there is a question mark for that. Bariatric surgery, it has a place where in rare situations where there is a patient has a patient is morbidly obese. Here I have given you just for a revision this BMI, going to call it as overweight and obese for our own convenience. How weight loss helps in patients with PCOS. Now, my request to all the postgraduates is this vicious cycle of PCOS. Even if you close your eyes and you are asked physiology of PCOS, you should be able to draw it. It should be by heart to all of you, where it shows on one side hyperandrogenism and on the other side hyperinsulinemia, and how both are again and again strengthening each other. That is why it is called as a vicious cycle. As the years go by, this vicious cycle becomes stronger and stronger, and then it becomes very difficult to even break it. But weight loss helps in breaking this vicious cycle. How it breaks is with the weight loss, there is reduction in insulin resistance. That itself will reduce the secretion of insulin, and that will help in reduction of the androgen secretion by the ovary. Secondly, whenever there is obesity, especially androgenic obesity, where there is a central obesity, we call it as androgen fat whenever there is a fat deposition over the abdominal wall. So this androgenic fat is a factor which reduces the SHBG and increases the free androgen level. But whenever there is a weight loss, there is improvement in SHBG, there is a reduction in free androgen levels, and that is how it helps in breaking the vicious cycle, and it helps in the features of hyperandrogenism also. First question, whenever a patient comes to us in OPD and we diagnose a patient as PCOS and we want to manage a patient with polycystic ovarian syndrome, the first thing which we need to ask is what is her main complaint, whether she wants to conceive or whether she doesn't want to conceive. If it is a young girl or a woman who is not interested in conception, then the first line of treatment is combined oral contraceptive pills. Whenever OC pills are contraindicated or not tolerated by the patient, then only progestogen supplementation can also be tried in the form of either cyclical or it can be given as intermittent. LNG-IUS, levonorgestrel secreting intrauterine system, is a very good option because it provides excellent protection for the endometrium as well as it acts as a contraceptive. If she wants to conceive, then obviously ovulation induction is the first line of treatment. But for both the situations, whether she wants to conceive or doesn't want to conceive, what is very, very important in obese and overweight women is weight reduction, because it will help even in ovulation and conception also. And it will help here also for reduction in hyperandrogenism as well as for reduction in the menstrual disturbances with improvement in HPO axis. Secondly is a metformin, which has a bigger role to play in patients with PCOS, and mainly whenever there is an impaired glucose tolerance. In these women, metformin will be the first line of treatment, whereas in others, it will not be the first line, but it will be the second line of treatment, even for ovulation induction, for hyperandrogenism, for weight loss, all these, its place is mainly as a second line of treatment. This is just a revision which we have already seen. What types of menstrual dysfunctions or AUB is common. Abnormal uterine bleeding is common in PCOS. Most common is infrequent cycles. Then there are irregular cycles also. Prolonged bleeding whenever there is a bleeding which is occurring after 2 to 3 months of amenorrhea, it is lasting for more than 8 days, and heavy menstrual bleeding is also a common form of abnormal uterine bleeding, and you take the history as per this FDRV, that is the mnemonic whenever we are taking a menstrual history in any gynec case. So for AUB as well as for endometrial protection, the first drug of choice is always a combined oral contraceptive pill in a patient with PCOS who is not desirous for conception. There are newer alternatives which are emerging, such as combination estrogen-progestogen combination, vaginal rings, Nuvaring, Novera ring. These are the emerging options where patients are not tolerating oral contraceptive pills and there are more side effects. We can always go for these better options. These are the newer ones which are not very easily available, but wherever available, they are showing good results in patients with PCOS. Even transdermal patches, combination transdermal patches are also available now, and they are also being tried at present in patients with PCOS, mainly to reduce the side effects because of the oral supplementation. Now, whenever combined oral contraceptives or combination of estrogen progestogen preparations is contraindicated or it is not tolerated, then in that case the second drug of choice is progestogen. It can be given as an oral form, as continuous or intermittent. It will protect the endometrium and it will also reduce the heavy menstrual bleeding in patients with PCOS, and it will help in regularization of cycles also. Or it can be given as intramuscular, injectable form, or even other forms are also available, such as subcutaneous, or it can be given as vaginal form, or intrauterine preparation is LNG IUS. Progestogen protection for infrequent cycles is specially recommended whenever a patient doesn't want to take cyclical oral contraceptive pills. Then in that case, if she fails to get her cycle, then after a wait of 1.5 to 2 months, for 12 days progestogen to be given, that will provide the protection for the endometrium, and it will prevent the occurrence of endometrial hyperplasia and endometrial carcinoma. So we need to educate the woman with PCOS. She should not be waiting for 3 months, 4 months if there are infrequent cycles. She has to take the progestogen withdrawal, and she has to take the progestogen for withdrawal, and progestogen supplementation needs to be taken not for 3-4 days only. It needs to be taken for 12 days so that the effect of unopposed estrogenic action which is on endometrium gets nullified by this effect of the progestogen for prevention of endometrial hyperplasia as well as endometrial cancer. Combined oral contraceptive pills in PCOS always now, whenever we are using COCs, we are always using low dose pills. Definition of low doses: whenever the dose of ethinyl estradiol is less than 50 microgram. So now whatever preparations we are having, usually all the preparations are having ethinyl estradiol 20 to 35 microgram. Now, the progestogen in COS combined oral contraceptive pills, especially in patients with PCOS, if patient can afford, then it has to be lipid friendly, such as desogestrel, or anti-androgenic, such as drospirenone or dinogest, because already there is a hyperandrogenism, and whenever we are using these anti-androgenic progestogens, the effect of combined oral contraceptive pills to reduce hyperandrogenism will be further enhanced. But cheaper COCs, cheaper ones which are having levonorgestrel, these are also effective in taking care of menstrual dysfunction as well as features of hyperandrogenism. So what are the advantages? If we are asked why you want to give combined oral contraceptive pills in a patient of PCOS, suppose you are asked this question in your table viva, your answer should be it helps in patients with a menstrual dysfunction such as correction of infrequent cycles, reduction in the duration of bleeding, regularization of the cycles, and reduction in the volume. Heavy menstrual bleeding also reduces, so that it helps in improvement in the physical, social, and psychological impacts of the abnormal uterine bleeding. What is more equally important is it leads to the reduction in hirsutism and acne also. Hirsutism, acne, alopecia, features of hyperandrogenism. For that also combined oral contraceptive pills are helping the patient. And with that, along with that, it prevents occurrence of endometrial hyperplasia or endometrial carcinoma in these patients with polycystic ovarian syndrome. Now, how it is helping? What is the mechanism of action? It is just dependent on again what we have seen as the vicious cycle only. Here the starting point, estrogen is mainly acting on liver and leading to increase in sex hormone binding globulin, reduction in the free androgen. And with that reduction in free androgen, what is happening is it takes care of all the features of hyperandrogenism. That is the main action of the estrogen here. Estrogen also acts on pituitary and it reduces the FSH, and that is why there is a contraceptive action also of these oral contraceptive pills. Progestogen component on the other hand is mainly responsible for endometrial protection. Together they are leading to regularization of the cycle and reduction in the bleeding. Progestogen also acts on pituitary, reduces LH, which was the starting point, especially in lean PCOS, and that is how it reduces the androgen production from the ovary. and that helps in taking care of our hyperandrogenic features. Now, these oral contraceptive pills also, they will have some effect on adrenal also, and it has been seen that there is a reduction in DHEAS also, dihydroepiandrosterone sulfate also secretion by the adrenal also reduces whenever a patient is taking oral contraceptive pills. Whenever levonorgestrel containing pills are given, levonorgestrel specially reduces 5-alpha reductase activity. There is reduction in dihydrotestosterone, and that is how it really further helps in the reduction in hirsutism, acne, alopecia. If we are using beta progestrogens, which are slightly expensive as compared to levonorgestrel, these have anti-androgenic action. They are blocking the androgen receptors, and that also further it will help in reduction of the features of hyperandrogenism. So OC pills are taking care of hyperandrogenism. They are acting as contraceptives. They are improving the menstrual dysfunction symptoms, as well as they are providing the protection against development of endometrial hyperplasia and endometrial carcinoma. So these are the 5 actions. Number 1, number 2, number 3 is mainly related to uterus, endometrial protection, regularization of cycle, reduce bleeding. Then 4th is contraception, and 5th is reduction in the features of hyperandrogenism. And this diagram shows how it leads to, what is the mechanism of action of these combined oral contraceptive pills whenever we are giving these in patients with PCOS. Now, why we say that combined combination pills, that is estrogen and progestogen, that is a first line, and if patient cannot tolerate or patient if it is contraindicated, then only we can go for progestogens. Why? Now here this is the our vicious cycle which we have seen, and COCs are breaking it by there is a with combined oral contraceptive pills, uterine protection is there, reduction in LH is there, there is increased SHBG is there with the estrogen. But what happens if only progestrogens are given is this estrogenic benefit, the blue color shows the estrogenic benefit, that is not there. What is happening with progesterogenic, only progesterone supplementation is protection to the uterus will be there, reduction in the LH secretion and reduction in androgens will be there, but additional benefit of estrogen, which is mainly reduction in free androgen, reduction in free even E2 estrogen also, that is also helping in reduce this protection of the endometrial hyperplasia. Hyperestrogenism is leading to that, and estrogen is taking care of that also. So that part, half part of the combined oral contraceptive pills is missing if we are giving only progestogens, and only progestogens sometimes are not very effective as contraceptives also if they are given intermittently. If they are not given continuously, even contraceptive action is also weak. Now, US medical eligibility criteria for contraceptive use has provided us with 4 categories for the use of any contraceptive. First category is when there is no problem and it is safe to use the contraceptive. That is oral contraceptive pills. We are talking here about that. Second is where advantages outweigh the risk. Third is where risk outweighs the advantage. And fourth is where it is not advisable to give it. In other words, absolute contraindications will be coming here. So if a patient of PCOS comes and if you are or anybody, we are prescribing combined oral contraceptive pills, what we need to understand is there are certain absolute contraindications, such as if a patient is a smoker and smoking more than 15 cigarettes per day and her age is also more than 35 years, you can't prescribe these contraceptive pills. If it is uncontrolled hypertension with systolic more than 160, diastolic more than 100, it should not be given. If there is a diabetes with vasculopathy, diabetic retinopathy, diabetic nephropathy, neuropathy, you don't give it. And if it is a diabetes which is long standing, it is of duration of more than 20 years, then also it is not advisable to prescribe oral contraceptive pills. In other words, we need to take blood pressure, we need to do the blood sugar, and we need to take a history of whether patient is a smoker or not whenever we are prescribing these oral contraceptive pills in patients with PCOS. Relative contraindications will be a elderly smoker, though the number of cigarettes is less than 15, blood pressure between 140/60 systolic or 1900 diastolic, and presence of dyslipidemia. If dyslipidemia is there, then we are worried about its effect of oral contraceptive pills on the lipid metabolism, and that is why it comes under the category 3, where the risk outweighs the advantage. Whereas advantage outweighs the risk is whenever there is a age is less than 35 years and patient is smoker. Controlled hypertension we can prescribe because advantage outweighs the risk, and in obese patient also this oral contraceptive pills can be prescribed. In the category, the safe category, we have age doesn't have an impact. Even if the age is more than 40 years, we can confidently prescribe OC pills in patients with PCOS. Just patient with a history of gestational hypertension, we can prescribe, and patient who has depression, in that category of the patients also, there is no problem for prescribing oral contraceptive pills. So this is, I think, we should be remembering this, especially in OPD also. Whenever we are prescribing oral contraceptive pills, we need to take proper history, we need to examine as well as we need to investigate lipid profile and blood sugar, GTT, like that, before we initiate this treatment of oral contraceptive pills in any patient with PCOS, irrespective of the age of the patient. So that this is another, again, the same thing I have given it as absolute contraindications and relative contraindications. This is category 4 and this is category 3. Now next, we have seen how we manage menstrual dysfunction and how we protect the endometrium in patients with PCOS. Now second component of the management is when a patient has hirsutism, weight reduction and combined oral contraceptive pills. We have already seen both of these are increasing the SHBG, reducing the free androgen, and they are having a great impact as far as reduction in hirsutism goes. Cosmetic measures are usually widely used by patients only, and they are also effective, such as hair removal by doing the threading or waxing or even laser treatment. Eflornithine is the topical agents which needs to be applied over the area where the hirsutism is present, and that is also effective in reducing the hair growth, undesirable hair growth. Anti-androgens, whenever they are being used, they should be used whenever the free androgen index is more than 5. What is free androgen index is whenever it is the total testosterone divided by SHBG into 100. And if whenever it is more than 5, it is suggestive of hyperandrogenism in patients with PCOS. Free androgen index is an investigation. So if free androgen index indicates presence of hyperandrogenemia, then we should be considering anti-androgens to be used in patients with hirsutism in PCOS. But we should be, what is more important is whenever anti-androgens are being used, we need to advise some effective contraceptive, such as intrauterine contraceptive devices, whenever these anti-androgens are being used, because accidental pregnancies, and if it is a male fetus, it can get affected with the anti-androgenic drug. Spironolactone and finasteride are the two drugs which are used in patients with PCOS. What is not recommended for hirsutism is metformin, inositols, statins, and vitamin D. So evidence at the present day evidence does not support use of these drugs in patient for improvement in hirsutism in patients with polycystic ovarian syndrome. Alopecia management is same as almost as hirsutism. Spironolactone is used, finasteride is used, topical minoxidil is used, and hair transplant is required in majority of the women. Now we come to the next part of the management of PCOS, that is in patients who are presenting us with subfertility or infertility, where the cause of infertility is because of anovulation. Now, since many years we are using clomiphene citrate as a drug of choice for induction of ovulation in patients with PCOS, but the current trial, especially pregnancy PCOS 2 trial, has shown, it was a randomized control trial which was conducted, and it has shown the superior efficacy of letrozole over clomiphene citrate for ovulation induction in patients with PCOS. So that is the reason why most of the guidelines as well as most of the textbooks, recent editions, are now recommending letrozole as the first line treatment in patients of PCOS for ovulation induction. Its mechanism of action is it is an aromatase inhibitor. It acts on the ovary and it inhibits the aromatization of androgens to estrogens, so that the release of E1 and E2, that is estrone and estradiol, from the ovary is reduced. Now, with the reduction in the amount of estrogen, negative feedback over the hypothalamus and pituitary is no more, and that is how it leads to the increase in secretion of GnRH and FSH, leading to the induction of ovulation. Initial dose is 2.5 milligram, and the dose can be increased up to 7.5 milligram. What is very important to understand is it is a first line drug, as well as whenever there is a clomiphene citrate resistance, patient comes with that, then also it is seen that it is effective in these cases also. Clomiphene citrate is less effective in PCOS as compared to the letrozole, according to the pregnancy PCOS trial 2, as we have already seen in the last slide. But there are still certain guidelines which are following the clomiphene citrate as well as letrozole, any of these two, as the first line of treatment for ovulation induction in patients with PCOS. Its mechanism of action is it acts as a selective estrogen receptor modulator. It blocks the estrogen receptors at the level of hypothalamus. So once the estrogen receptors are blocked, then the negative feedback which is there because of the estrogen on hypothalamus is no more, and that increases the secretion of GnRH, and pituitary also secretes more of FSH, and that is how it leads to induction of ovulation. So letrozole acts directly on ovary, whereas clomiphene citrate is acting on at the hypothalamic level with the blockage of the estrogen receptors. Initial dose is 50 milligram. It can be increased up to 150 milligrams. Now, should we be using insulin sensitizers for ovulation induction? Role of metformin. So, as per pregnancy PCOS trial 1, there is still a question mark about whether to give metformin to improve the results of clomiphene citrate or letrozole just for ovulation induction. At present, it is not the first line of treatment. Inositols, metformin with rosiglitazone, these are also not showing, the evidence doesn't show improvement in the efficacy if these drugs are given for ovulation induction along with the either letrozole or clomiphene citrate. So at present there is a question mark. Metformin is not given routinely to improve the results of ovulation induction. Laparoscopic ovarian drilling for anovulation has a limited place. It has a short lasting effect. That means you do the laparoscopic ovarian drilling for next few months only, the ovaries are responsive to the ovulation induction. Potential sequelae are pelvic adhesions, decrease ovarian reserve, and increase in anti-Mullerian hormone. Either when you can do it as a dial with the help of laser or diathermy. Number of pricks needs to be, it is still the evidence is not there how many pricks are to be there per ovary, and whether it should be done as a unilateral or bilateral procedure. These are the questions at present. So it has a limited place, and especially with better medical management of anovulation, it has less limited place or less space, especially in resistant cases only it can be tried. But what is recommended? So if there is no pregnancy with ovulation induction, it is recommended that in patients with PCOS, one should directly send the patient for in vitro fertilization rather than trying in a smaller setup giving gonadotrophins. The reason is with gonadotrophins in PCOS, what is the major challenge is there is so much of increase in ovarian hyperstimulation syndrome and multifocal pregnancy. And there is a very small therapeutic window. What does it mean by small therapeutic window is even at a lower dose also there can be OHSS or multifocal pregnancy. So slight increase or slight reduction in the dose is reflected with enhanced effect in patients with PCOS as compared with to the other patients. There is a definite role of metformin. The emerging evidence shows that whenever metformin is given along with gonadotropin, there is a reduction in ovarian hyperstimulation syndrome whenever IVF is being done in patients with PCOS. So here there is a definite role for metformin in patients of infertility, that it should be given along with gonadotropins in patients with PCOS, as it significantly reduces the risk of ovarian hyperstimulation syndrome. Now, what is if you are asked in your table web also, sometimes if you are given a drug metformin and you are asked, now explain what is the place of metformin in patients with PCOS, what should be your answer? Your answer should be there is no doubt that it is indicated, clear indication is there in patient with PCOS whenever a woman has impaired glucose tolerance or diabetes mellitus. So if it is a diabetes mellitus or impaired glucose tolerance, there is a definite place of metformin in patients with PCOS. It is also definitely indicated whenever we are going for IVF to reduce, and gonadotropins are being used to reduce the incidence of OHSS in patients with PCOS. Now, for weight reduction, lifestyle modification is first line, and use of metformin for weight reduction is not recommended at present. Similarly, for ovulation induction, it is the present evidence indicates that for ovulation induction, the use of metformin, the randomized controls trials are not giving clear indication that it improves the outcome. So there is a query about that. For hyperandrogenism also, as though theoretically we can say that metformin will reduce hyperinsulinemia and it will reduce the hyperandrogenism by breaking the vicious cycle, but the studies have not shown, randomized controlled trials have not shown the clear-cut benefit. Now, whether we should be giving metformin whenever a patient conceives with PCOS, with the rationale that it will reduce the pregnancy complications of PCOS. PCOS is a risk factor for recurrent pregnancy loss, early pregnancy loss, preterm labor, hypertension in pregnancy, so whether or gestational diabetes. So whether we should be giving metformin, there is still the evidence is not very clear. But if already patient is taking metformin for treatment of infertility and she conceives, then the metformin should be continued in the first trimester. It does not lead to any teratogenic effects and it has no untoward action. And in these cases, it can be given even in first trimester. Other insulin sensitizers, there is no even at present no enough evidence for isolidiadones, D-inositol or myoinositol. These are the other insulin sensitizers, and there is no clear-cut evidence at present to support their use in patients with PCOS as insulin sensitizers. So this is just to explain metformin will be acting here, reducing the insulin resistance in the vicious cycle of PCOS. Estrogen of combined oral contraceptive pills and weight reduction will be acting on liver. It will lead to increase in SHBG and reduction in free androgen. Whereas if we are giving combined oral contraceptive pills or progestrogens, that will reduce the LH and that will reduce the androgenic microenvironment and androgen production from the ovary. So that is our goal. We need to reduce the insulin, hyperinsulinemia. If it is there, we need to reduce LH level. Whenever LH level is more, we need to reduce the hyperandrogenism and we need to increase SHBG. And what is very, very important is insulin resistance. If there is insulin resistance, That also needs to be taken care of in patients with PCOS. Now we know that in the management, the part of the management is also prevention of sequelae as well as early detection of the long-term complications or sequelae of PCOS, and one of that is endometrial hyperplasia and endometrial carcinoma. So when should we do the endometrial sampling, endometrial biopsy? What is very important to understand is it is not dependent on age. It is not age dependent. Even in younger women also there can be carcinoma endometrium in patients with PCOS. What is very important is how much is the duration of untreated chronic anovulation. That is a risk factor rather than advancing age. Now, normally we say that in reproductive age group, to 12 millimeters endometrial thickness is normal. But in PCOS, even with a normal endometrial thickness also, there can be presence of hyperplasia or carcinoma. And that is the reason the cutoff is not 12 millimeters, it is 7 millimeters. If it is more than 7 millimeters, should be considered as a risk factor for endometrial hyperplasia or carcinoma, and endometrial sampling should be done. What we need to take into consideration is how much is the severity of obesity, severity of hyperandrogenism, and severity of insulin resistance. Hyperandrogenism, as more unopposed estrogenic action will be there by conversion of androgen to estrone. Insulin resistance, insulin itself acts as a growth factor, and it leads to endometrial hyperplasia and ultimately endometrial carcinoma. So these are all independent risk factors apart from anovulation. Anovulation is a risk factor, but obesity, hyperandrogenism, insulin resistance, these are all independent risk factors for development of endometrial carcinoma in patients with PCOS. What is metabolic syndrome is, we know that metabolic syndrome is one of the common sequelae of PCOS, any three of the five features. So we need to take the blood pressure at every visit. Anytime it is more than 130 systolic, more than 85 diastolic, it is one of the feature. Any three of the five features, one of the feature of metabolic syndrome. We need to do the fasting blood glucose level, and if it is more than or equal to 100 milligram per dl, then also it is one of the feature. We need to do the lipid profile. Rising triglycerides, fall in the HDL is also one of the feature of metabolic syndrome. And central obesity, especially waist circumference more than or equal to 88 centimeters, so that whenever we are examining the patient, we should be taking a waist circumference also, or the ratio of waist to hip. Whenever it is more than 0.85, that is also suggestive of a central obesity. So we need to be examining the patient with these mainly to detect whether she has a metabolic syndrome, because metabolic syndrome increases the risk of diabetes, ischemic heart disease as well as stroke. So in PCOS, it needs a multidisciplinary approach. Gynecologist is required for taking care of menstrual dysfunction, endometrial protection, infertility specialist, especially anovulation, and because we know that IVF might be required in some patients, obstetrician because of the complications which are seen with the patients with PCOS, physician to take care of obesity, impaired glucose tolerance or diabetes, dermatologist for hirsutism, acne, alopecia whenever we want to give anti-androgenic drugs, endocrinologist for overall detection and correction of metabolic syndrome. Surgeon might be required for bariatric surgery in extremely obese women, especially for depression, anxiety, and eating disorders. We should be taking this psychological history also in patients with PCOS and referring them to the specialist care, because it is seen that PCOS is associated with increased risk for all these depression, anxiety, eating disorders. Then, if there is a history of snoring, especially that's we ask the patient's partner, and if there is a sleep apnea, that is snoring and daytime exhaustion or feeling of inadequate sleep, then patient needs to be referred for to the sleep medicine specialist. Dietitian will take care of the proper diet, especially for weight reduction, if patient has impaired glucose tolerance or diabetes, and as well as for dyslipidemia. So it is a multidisciplinary approach in patients with PCOS. What to read to prepare PCOS? My recommendation is for postgraduate students is Spiroff gives it beautifully. It is better to read this topic from Spiroffs, as I believe that the basis to understand polycystic ovarian syndrome lies in its pathophysiology, and pathophysiology has been given with greater clarity and in detail in Spiroffs. The pathophysiology helps us to understand even the diagnostic criteria, diagnosis, as well as which investigations are to be done in patients with PCOS, and even the treatment modalities, why we are selecting a particular type of treatment. So whole topic, the basis or the main thing about the PCOS which needs to be understood, basic concept is lies in pathophysiology. So that is the reason I found Spirops to be very, very useful to prepare this topic of polycystic ovarian syndrome. Sometimes it feels as a difficult topic of gynec endocrinology, but if you read Spiroff and understand it, then you will find it more beneficial. Thank you so much. If you have any queries or you need to communicate for any other topics, then you are most welcome to write so in comment box. Thanks a lot.